I'm Neal Kleiman. I'm chief of the section of interventional cardiology within the Department of Cardiology at Houston Methodist Hospital. And I'm going to talk to you today about one of the areas within our structural heart division that we're entering and that we're really very excited about. And in fact, I have to confess to you that the more I prepared this talk, the more excited I got about it. This is a subject that really is near and dear to us. And as all of us get older, it's going to be nearer and dearer to us because I think many of us and many of you listening are going to end up in this category. So I'm going to talk to you about assessing valve expansion in patients undergoing TAVR. So look, if you follow TAVR, you know that it's become more popular. In 2019, TAVR overtook SAVR in popularity in the US. And currently we have more than 800 centers performing TAVR, more than 100,000 TAVR procedures as compared to about 63,000 surgical AVRs. Now, if you look further into TVT, that is the transcatheter valve registry, the one thing you'll see is that the number of patients in the low-risk category has risen. Remember, we started doing TAVR in extreme risk patients, then moved to high risk, then intermediate risk, and now we're including patients who are at low risk. And that group comprises approximately 30% of the TAVR population in the US now, with a mean age in the mid-70s. That's important because that means there are a large number of low-risk, relatively young patients undergoing TAVR, and this group poses unique challenges to us. So we're no longer concerned about mortality. Hospital mortality in this group is less than 1%. Stroke risk is now quite low. One of the major things that we're concerned about is lifetime management. And to give you an example, one of our ex-fellows, who's now practicing in New England, published a very important study last year in which he noted that among patients aged less than 65, half of those patients who undergo aortic valve replacement are having it done with a transcatheter rather than a surgical technique. And 17% of patients had bicuspid valves. So these are groups in whom we really don't know a lot about the long-term outcomes of TAVR, but in whom what we've called lifetime management becomes a very serious issue. Now, what does that mean? Well, if you look at survival in the Swedish registry of patients who've undergone AVR, and obviously because we're looking at long durations, that's going to be surgical AVR. If you're in your 60s, your median survival is about 12 years. Hopefully, TAVR with a lower procedural mortality will have a somewhat higher survival. But it also means that many of those patients are going to outlive their valves, and we'll have to think about what do we do next. So one of the issues that faces us is valve durability. And in the last year or two, much of the focus on valve durability has actually come to land on the issue of valve expansion. Is the valve implantation adequate? Meaning, is the valve adequately expanded? Is it adequately circular in position? And remember, you're implanting a valve in a rigid, irregular, often oval landing zone. And do the leaflets coapt appropriately, or do they pinwheel because the valve isn't adequately expanded? So if you look at some of the data that have been published, more than 50% of implanted TAVR valves have a greater than 10% underexpansion. And 10% is basically the number that flow chamber studies have identified as being the cut point for optimal versus suboptimal flow patterns and maintaining laminar flow in the valves. And when you look at valve implantations, 70% of valves are underexpanded. Now, one thing that's become clear is that as you increase the degree of underexpansion, that is, if you look at patients with progressively greater degrees of underexpansion and greater deformation or loss of circularity of the valve, the risk of leaflet thickening, and it's abbreviated here as HALT, hypoattenuated leaflet thickening, increases. Now, we don't really know these data for valve durability because we haven't been aware of this long enough to follow these patients long term, but certainly valve thickening is something that you do not want to see, and something that, at least now, we would reason is a precursor to early valve failure. Among patients with significant valve frame underexpansion, there are several studies that now tell you that the risk of leaflet thickening is increased somewhere between 6 and 8-fold among patients who've got significant valve frame underexpansion. In addition, 2 months ago at the TCT meeting, my colleague Dr. Reardon presented data from the ACURATE pivotal trial, which, among other things, showed that about 20% of patients had underexpansion of the ACURATE valve. And when you compared that group to patients with adequate expansion, the likelihood of mortality was significantly increased at 1 year. In fact, if you take all these data together, it looks as though the cost of having an underexpanded valve is really a good deal more than we originally thought, as we were really getting our feet, ankles, and possibly knees wet in TAVR. But now that TAVR has become mainstream and is being performed on younger patients with longer horizons, we really have to take this issue very seriously. So let me show you a case, if I may. This is a valve we implanted recently in a patient in their 70s. And what you can see is that when this valve was expanded, it was initially infolded. You can see this line. And the way we manage this is by a vigorous balloon inflation. And in fact, you can see that the valve is no longer infolded. However, that doesn't tell you it's adequately expanded. Let me show you what we did next. We didn't feel comfortable going to ever larger balloons, but we still felt we needed to know how well we had expanded this valve. So we did a non-contrast CT the next day. And this is the reconstructed image. You can see the valve. In this view, it looks quite nicely. But as you manipulate this image, rotate it, and look down the barrel of the valve, you can see that it's still elliptical. And in fact, when we look at the multiplane reconstruction of the valve, you can see that it's not fully expanded. Toward the inflow, it's still relatively constrained. And if you look at a cross-sectional area, it's still relatively elliptical. And it's got an ellipticity index, meaning the ratio of the minor diameter to the greater diameter of 1.4 on CT. So I won't say we know what to do with these valves, but at least it's a consideration when you're choosing a valve size. Do we choose a larger or smaller valve, knowing that a larger valve may not be able to be expanded to be perfectly circular. And we don't really know what degree of ellipticity is going to be acceptable. But these are things we have to assess. Now, if you're concerned about asymmetric valve deployment or valve underexpansion, how do you assess that, and when do you assess it? Ideally, you'd like to assess it while you're in the OR or in the hybrid cath lab, so that if you want to balloon dilate it, you can go ahead and do so. Now, it's very common to say, well, I'm not quite sure. We can always come back and do it, but that's a big undertaking, and it's often honored in the breech, so to speak. So how can you assess that in the lab? Well, there aren't many readily available ways. One thing you can do is do a cone beam CT, which in some systems involves rapid rotation of the X-ray gantry around the patient. That's fairly cumbersome to set up when you're in the middle of a procedure. It involves a lot of radiation, and it doesn't necessarily give you great images. One thing we've looked at is creating a cath lab hybrid OR with a built-in CT scanner. So in fact, a patient could go directly, while it's actually still on the table, from the X-ray gantry to the CT scanner, have a rapid and low radiation scan done, and then come back to the X-ray gantry. We don't have that in place now, and very few places do. It's a fairly expensive undertaking. I don't know if it will ever happen. But there's a third option that we are actually taking our first step to investigate. And this is a study protocol that we are in the process of getting through our IRB. Is led by one of my younger colleagues, Dr. Joe Allen, and that we'll be starting very shortly. And that will involve using intravascular ultrasound. Same way you do it if you were working on a coronary stent. Is the stent adequately expanded? Is it circular? Is it making adequate contact with the vessel wall? You'd ask very similar, not identical, but very parallel questions here. Is the valve circular? If it's a supraannular valve, by the time you get up to the valve leaflets, is that portion of the valve circular? Are the leaflets meeting appropriately? And this is done with a large-scale ultrasound that we insert intravascularly, just as we do in the iliacs when we're doing intra-iliac ultrasound. So that's something that we will be starting soon. We'll be evaluating patients with self-expanding as well as balloon expandable valves. And we hope to correlate that with CT scan findings and determine whether that will be useful in the lab or in the hybrid OR in helping operators decide, do they need to perform a post-dilation? And our hope is that eventually that will have an impact on valve durability, on patient lifetime management, and decrease the number of times a patient will have to undergo a procedure. Thank you.